Laryngomalacia. This is a common condition of unknown etiology where the larynx is floppier than normal. The epiglottis is large and differently shaped. The arytenoids are also floppy, and on inspiration the larynx collapses inwardly, obstructing the airway, causing stridor. Stridor is present usually after birth, is louder on inspiration, on crying, and when there is an upper respiratory tract infection. Laryngomalacia does not cause difficulty in breathing or feeding unless it is severe, but it can be associated with apnea. If severe, there can be subcostal recession due to obstruction of the airflow. The baby's voice should be normal in laryngomalacia. It's thought to represent a delay of maturation of the supporting structures of the larynx. It's very important to remember that laryngomalacia is the most common cause of congenital stridor, and it is the most common congenital lesions of the larynx. Laryngomalacia affects the epiglottis, the arytenoid cartilage, or both. When the epiglottis is involved, it's often elongated and the walls fall in on themselves. The epiglottis in cross-section resembles an omega, and the lesion has been referred to as an omega-shaped epiglottis. If the arytenoid cartilages are involved, they appear enlarged. In either case, the cartilage is floppy and is noted to prolapse over the larynx during inspiration. A classification system has been proposed. Type 1 laryngomalacia. The epiglottic folds are tightened or foreshortened. Type 2 laryngomalacia is marked by redundant soft tissue in any area of the supraglottic region. Type 3 is associated with other disorders such as neuromuscular disease and gastroesophageal reflux. Infants with laryngomalacia have higher incidence of gastroesophageal reflux, presumably as a result of more negative intrathoracic pressure necessary to overcome the obstruction. Children with significant reflux may have pathologic changes similar to laryngomalacia, especially enlargement and swelling of the arytenoid cartilage. Occasional inflammatory changes are observed in the larynx, which is referred to as reflex laryngitis. When the epiglottis is involved, gravity makes the noise more prominent when the baby is in supine position. The exaggerated inspiratory effort increases blood return to the pulmonary vascular bed, and this could account for the increased likelihood of pulmonary artery hypertension in infants with hypoxemia. Late onset laryngomalacia can be a distinct entity which can present after the age of 2 years. Laryngomalacia clinically presents with inspiratory noises that begin during the first 2 months of life. Sounds typically start at the age of 4 to 6 weeks, but they may begin in the nursery or as late as 2 to 3 months of age. Noises are inspiratory and may sound like nasal congestion, with which they are initially confused. The noises often increase when the baby is in supine position, during sleep, during agitation, during upper respiratory tract infection, and in some, during and after feeding. The baby's cry is normal unless concomitant reflex laryngitis is present. No feeding intolerance. Occasional choking, coughing may occur. Noises may increase during and after feeding. The infant is usually happy and thriving. Upon examination, the baby is usually happy and appropriately interactive. Mild tachypnea may be present. Other vitals and oxygen saturation is usually normal. One can usually detect nasal airflow. Noise may be increased if the baby is placed in supine position. The cry is normal. The noise is purely inspiratory, best heard just above the sternal notch. Differential diagnoses that may be confused with laryngomalacia include congenital stridor, croup, hypocalcemia, respiratory papillomatosis, airway foreign body, gastroesophageal reflux, and subglottic stenosis. Laryngomalacia can be diagnosed with history and clinical findings of a well child with stridor. Infants with difficulty in breathing and feeding do need visualization of the upper airway using flexible laryngoscopy. If the result from the laryngoscopy is normal in a child with persistent stridor, indicates the need for flexible or rigid bronchoscopy. The following findings can be found: omega-shaped epiglottis that prolapses over the larynx during inspiration. Enlarged arytenoid cartilage that prolapses over the larynx during inspiration may also be present. Treatment. In more than 90% of cases, the only treatment necessary for laryngomalacia is time. The lesion gradually improves and noises disappear by age 2 years in virtually all infants. In severe cases, in which the laryngomalacia interferes with ventilation, enough to impair normal eating, growth, and development, a surgical approach is possible.